Today I'll discuss a case of a patient with lower extremity, hip, groin, low back, and buttock symptoms. And it's an interesting case for a number of reasons, which I'll highlight throughout this talk. I'll try not to be too wordy, but one of the things that this case brings up is just value of care. By the time this patient had seen me, this patient had already been to a physician, more than one physician, already been to a physical therapist, and then been to a second physical therapist. And so not only had the cost accumulated in terms of visits, but the patient had also had MRI of the hip, MRI of the low back, X-ray of each hip, and an X-ray of the spine. So I know there's a lot of, ambiguity in terms of cost in the United States because of people being in network versus out of network. For example, I am a cash-based practice. I choose not to have non-medical insurance companies dictate how I perform my care with my patients. I believe that allows me to offer the best care. Most of these providers, if not all the providers this patient had seen before me, were in network, so I think in theory her insurance was directly accepted. So I obviously don't know the cost of all those services, but it's definitely in the thousands of dollars. I saw this patient, and to my knowledge, she was reimbursed to a large extent from her insurance company to see me, but I saw her for a total of 6 visits, which is $1,000. And so in contrast to 6 visits with successful resolution of the patient's symptoms versus thousands of dollars, and you could argue possibly negative impacts with MRIs of hips and low back, which for some people, those findings can cause more fear in patients than they're worth. That type of care over those several months was definitely a lot more than $1,000 and didn't achieve any resolution of the patient's symptoms. So one facet of this case that's interesting to me is just when we juxtapose the different types of care and the cost, we can't make that cost analysis perfect when we talk about in-network versus out-of-network, but people can get a good idea about the value of care if they start understanding what they are paying for these things. Of course, if you're not paying directly and your insurance company is paying directly for the care, those costs are passed on to most of us, and they are going to be passed on to the individual through premiums at some point. If the cost of care keeps going up, premiums for the insurance company, people who subscribe to that insurance company, their premiums will go up. So the patient presented, like I said, with all those different symptoms. Like I mentioned a lot, it's really important to understand where all the symptoms are. And so for her, it was left greater than right down into the leg, so below the knee. The pain will go into the calf. In terms of the hip, at the time I saw her, it presented just with right hip and hip area symptoms, nothing on the left. She reported right anterolateral hip pain and right groin pain. Buttock pain was there, right and left. It was very tender to palpation. And in the low back, this is not typical, but her presentation or her symptom that she noticed the most was tingling in the low back, but also some discomfort. So the symptoms had been there for approximately 7 months. They came about at the same time, roughly low back pain, glute, and hip. There was no trauma, so when I write down on my form, I write down no apparent reason. Symptoms were intermittent, but before the symptoms came on, she was a very active individual. Her job involves a lot of standing and bending, but not a lot of sustained sitting. She also likes to jog, likes to do exercise, kind of goes upstairs, 2 by 2 versus 1 by 1. She likes to move and stay active. And until this had started 7 months ago, she was very active, but now she was not able to be that active other than some elliptical. And she said she could row on an ergometer for 10 minutes without having an effect. So in terms of what makes her worse, sitting clearly made her low back and glutes worse. In the car, she said she could only last about 15 minutes because of the symptoms coming on. She reported that she got worse after about an hour of walking. It would radiate from the low back into the glutes and the hips. She was worse lying down on her back in terms of her low back symptoms. She noticed that she felt worse when she tried to go up 2 stairs at a time or step up onto a stool to do work around the house. And she said she noticed that she was better in standing and better lying prone, which is lying on the stomach. Most nights it was disturbing her sleep to some extent. Another thing I forgot to mention, in her prior care, she had already had spinal injections and hip injections. So again, that kind of increases the cost of that former care versus the current care. I also has been taking some prescription medicines for the pain. So I did get kind of thorough notes from her prescribing physician, and the prescribing physician had said that her pain now was hip dominant, when the physician did the evaluation, told the patient her symptoms in her hip were from the hip. I found something else, but she was very open to looking and exploring. What I tell a lot of patients with low back and hip complaints, the below the knee symptoms really make me think that the low back has a big component of the entire picture, if not 100% of the picture. So because I don't find that hips can refer below the knee, and that is known. Hips don't refer to the knee. If they do, it's very rare. So the fact that she had below knee symptoms make me think, again, mostly lumbar, possibly hip, but I do explain to a lot of patients, say this person did not have anything below the knees, I would say, look, these cases can be challenging to really deduce what symptoms are coming from what area of the body. This patient, for example, could have a lumbar complaint, a low back problem that's creating all of these symptoms. The patient could also have a low back problem and a right hip problem, or a low back problem and a left hip problem, or a low back problem and a left and a right hip problem. So there's lots of different kind of variations on what could be the cause. For me, I need to have a really clear way of attacking these types of problems. Otherwise, it just becomes a mess. If I start looking at the left hip and the low back on day one, it just gets messy. And then I can't really understand what's going on. And what I perceive my role to be, and it took several years to kind of really get this notion ingrained into my head, is that I'm a diagnostician first and I'm a treater second. So I'm not going to treat something that I don't understand. And it's my job to really understand what's going on. Then I can say, yes, I have the skill set or the tools to provide the adequate treatment, or no, I don't. I've had patients recently that have come to me and I've said on day one, we need an x-ray. And then I can't start treating this. We need an x-ray. We need to understand the diagnosis. I think the diagnosis is a fracture. I've had patients where I said, I think the diagnosis is inflammatory. Therefore, we've spent a few sessions trying to figure that out. That's my diagnostic conclusion. So we need to get some anti-inflammatory help. My role is to understand first what's going on. And yes, that can take more than a visit. It can take more than 2 or 3 visits, because each visit lends itself to more testing, because I use testing that's movement-based. But if we need testing outside my office, we can go get an x-ray or another type of test. But for these patients where it's kind of global around the low back, hip, into the buttock, into the thigh, I do explain to them that for some reason these are just more challenging because there's so many different areas of potential involvement. The neck and the shoulder do not create the same kind of conundrum, because we can move the neck without moving the shoulder, and we can move the shoulder without moving the neck. So the upper body is a different paradigm than the lower body. We can't move the low back without really moving the hip, and vice versa. We can't really move the hip without moving the low back. So if I start to try to move lots of different things at one time, and kind of like I said in a post recently, if I prescribe 2 things and the person comes back the same, I don't have good answers about what's going on. If you think that you're just prescribing 2 exercises as prescription and you know that's exactly what they need, that's a different story. But if you don't know exactly what they need, and I argue in orthopedics, you don't really know what a person needs on day one. On day one, if there's an ACL tear that's obvious, there was trauma to the joint, now the ACL ligamentous test is unstable, yes, you can be confident in that diagnosis and prescribe more than one thing. But if you don't really know, which I believe you don't in a patient like this, even if you have all these different images and I have all these tests I can do quickly on day one, I still abide by the philosophy that in the large majority of cases, I don't really know what's going on until I repeatedly move the body and assess the effect. and that is Robin McKenzie's contribution to orthopedics, is repeated movement testing. It's very algorithmic. Once you get good at it, and I'm getting better at it, the more I implement it over the years, you can use the cause and effect testing of repeated movements at home to really get to the diagnosis, or at least an understanding of what's happening. So I wouldn't prescribe two things for the hip and the low back, or the left hip and the right hip on day one necessarily, and then because I wouldn't get good answers coming back. If the patient's worse, I don't know which one made them worse, or if nothing made them worse, etc. And if best case scenario is they come back better, but I don't know if exercise 1 or exercise 2 made them better, or if it was the combo. So that's why I present to these patients now verbally that these can be challenging cases, but we're going to work together to figure out where each symptom is arising from. Lumbar joints, SI joints, hip joints. If it's the hip joint, which one? Possibly the knee, because there's below knee involvement, but probably not, because the clinical picture sounds more like it's a dominant lumbar problem with radiating or radicular symptoms below the knee. So so this patient on day one, in terms of a physical exam, lumbar flexion, moderate loss, extension, moderate loss, and standing. Side gliding to the right, no loss. Side gliding to the left, moderate loss. So to me, that's kind of the biggest thing is, okay, there's a really big difference moving the lumbar spine left to right. One way goes great. One way is pretty limited. Now, in terms of the neurological kind of, or myotomal exam, both plantar flexion, calf raises, single leg calf raises seem weak, right greater than left. Bilateral straight leg raise passive was about 60 degrees, but it was limited equally left to right. It was somewhat painful, but it was markedly decreased from what I would love to see for people, which is close to 90 degrees for a passive straight leg raise. But it was important to note that it was symmetrical. Hips, there was minimal to moderate loss in most ranges of motion, a little bit different in terms of left versus right, but there was some pain and minimal to moderate loss. So pretty symmetrical, but considerable loss of motion passively in each hip. I also wanted to see her extension in lying because she had previously worked with a physical therapist for a handful of visits who tried to or used the McKenzie method. I'm not sure if this clinician was certified or not, I forget, but it sounded like what I could gather was that the repeated movement testing wasn't used the way I use it, and that lots of other kind of treatment modalities were used with this patient. And this patient recognized that, and that's why she sought me out, because she thought I was kind of more trained, which I am, more trained in using the McKenzie method of repeated movement testing. And, I was in that place at one time in my career, of course. We all start somewhere, but when we use repeated movement testing, we're typically trying to use it to figure something out. And if it turns out to be fruitful, that becomes a treatment. So we're not typically pairing it with stabilizing, strengthening, electric things, heat, ice, dry needling, etc. So she said that she had been doing some extension and lying on her stomach. So I asked to see what it looked like. And it was very stiff. I put her at, significant loss, very little curve reversal of the lumbar spine, which may be due to the lumbar spine, but could also be due to hip immobility, because the hips have to extend well when you're doing lumbar extension. Like I said, it's hard to separate those two parts of the body when you're doing testing or when you're doing treatment approaches. So she did it well. It was just not a lot of curve reversal in the lumbar spine, not a lot of lordosis. So I wanted to look at sustain, possibly, to see if, moving it a little bit more slowly, obviously sustaining it would help increase that lumbar extension. Going on sustained on elbows was no problem. Initially it produced low back pain, but it got better. So I kind of increased the height, put her elbows up on a few books. No effect there. And then when we retested the baselines, there was decreased pain with the bilateral straight leg raises, increase in left side glide, and a slight increase in extension and standing. So because of this kind of, the fact that it's been there at least 7 months, the fact that this person's quite stiff in terms of joint mobility, I was happy with that small change in the office, right? It wasn't off the charts that now everything moves so much better, which you may see with a young patient or a younger patient who injured herself 3 weeks ago versus 7 months ago. But I was happy with going home with sustained extension. She did, that became the home program, sustained extension, elbows on a few inches of books. Also, we discussed car seat wedge, we discussed lumbar rolls, because sitting was so provocative for her at the moment. I also gave her the information that I wanted her to slowly increase the height of the sustained extension as tolerated. And this patient was very compliant and very smart, so she got what we were trying to do and she was able to comply. She came back on visit 2 a week later. She said she had a few days where she couldn't do it, but she kept a notebook and she kept a tally of how often she was able to do the sustained extension. And now what was initially right hip pain on day 1 was now left hip pain. She's like, the pain has moved to the left side. Now it feels like deep in the left hip socket. The right hip doesn't feel much, so that's improved. She still noticed the left calf pain a few times at night, but no more low back tingling. The car seat wedge helps a lot. She said now that before she could tolerate about 15 minutes of driving, now she could tolerate about an hour. But it brought up an interesting point of discussion for us, which is we only had her move her back, and yes, her hips are bilaterally in extension when she does sustained lumbar extension, but I think the effect was coming from the sustained extension of the lumbar spine, not the hips, although I can't prove it. It was interesting to note that she's like, the pain jumped from my right hip to my left hip. So clearly we're starting to think that the lumbar spine is influencing the hip symptoms. Her prior physician had mentioned to her that she thought it was hip dominant. And so I said, I think this is good evidence that we have a lumbar dominant problem. So we use now a step up in the office as a baseline. So I had her step up on the chair that my patients sit in, which is, 1.5 to 2 feet tall. It would create left hip pain. So that was a really good baseline, that a large step up like she does when she goes upstairs by 2, that's a similar thing. Straight leg raise was the same. Hip passive range of motion was about the same, but she looked a little bit better, a little bit more fluid with her lumbar movements in standing. So I asked her to perform the exercise. She showed me, it was good. I looked at mobilizations of the low back. We did mobilizations in prone. I wanted to assess what happens when we put a bit more extension force through the low back in particular. There was a slight improvement in the step up and other baselines. We looked at extension of the lumbar spine in standing. We know she'd been doing in lying quite a bit, but we wanted to look at standing. Again, slightly better. And so I decided, again, we have made some progress, but it's not off the charts. So I wanted to stick with continuing to focus on posture and keeping the lordosis in sitting when she was sitting, and try extension and standing at the counter. For many people over 60-ish, we tend to find that sustained extension of the lumbar spine or extension and standing of the lumbar spine is more effective than extension of the lumbar spine in prone. So it's just something we tend to find, but obviously we have to test with each patient and see which particular movement is best for that individual. But I wanted to look at extension and standing. It looked like she got more extension in her lumbar spine when she did that versus in lying. So we also said we could stick with some sustained, and if she wanted to get her husband to do some mobilizations like I did because she said it felt good, then we could stick with that. So I'm not typically having people do a medley of different types of extension, but for her it seemed appropriate because she understood that we wanted to find if there was one that was clearly better. So when there's patients who kind of get the process, we can be a little bit more fluid with kind of the prescription. But she knew she was still going to be getting something about every 2 hours. So visit 3 was 5 or so days later. She comes back and she reports that now she feels overall 70% better compared to the first visit. She's been doing the extension and standing 5 to 6 times a day. She would also kind of get on her floor and get her chest up on her ottoman and get some sustained extension once a day, and her husband would mobilize her back in prone on the floor once a day. So getting a lot of different extension through her lumbar spine. She feels like her range of motion is improving. She tried a night roll, which is something we had not discussed, but again, this person is kind of motivated to get better. So she tried putting a towel or a night roll behind her lumbar spine and sleeping to keep it more extended. She said it was uncomfortable at first, so she discontinued it, but the more she tried it, it became more doable. She'd been walking each day, going up and down the stair, or up at least the stairs by 2, and she knows a big improvement in her ability to do that without pain. She tried jogging, which was fine. and her legs at night were better. And so her right hip was better, her left hip was improving. So 70% overall it's a really great mark of improvement for visit number 3. Mechanically, when I looked at her, the chair step up was still positive in terms of left hip pain, the right was negative. The straight leg raise test was still about 60 degrees, passively bilaterally, but she didn't report the pain like she used to. The Faber and all the other hip passive range of motion tests still about the same. Maybe a little bit less pain, but it's still the same in terms of mobility. Lumbar mobility also kind of about the same. The side gliding on the left was a teeny bit better, but she still seems pretty stiff. So this is an interesting point too in terms of this case, is that, you know, I'm not seeing a huge change in her mobility, but we are seeing a huge change in her symptoms. So it makes me think that there is some movement going on, but because of kind of global stiffness, it's not something I can really appreciate with my naked eye in terms of the 4 movements of the lumbar spine. I'm more confident in side gliding assessment because that's more focused on the lumbar spine and I can feel it passively how far it goes. But when it comes to, you know, lumbar flexion and standing, toe touching, for example, we know that there are many different parts of the body that are involved. But for her, she was still reaching her mid to distal shins. She was not getting lower than that. So many patients I'm seeing quick, obvious, you know, visual changes in how much they move, hip or lumbar spine. For her, it wasn't quite that way, especially in terms of lumbar flexion extension and hip passive range of motion. So I did some more mobilization. She said it does help. I wanted to see directly if there was a big change in range of motion that I was missing with more pressure into the mobilizations. And there was a little bit improvement in the hip range of motion, but nothing quite clinically significant. We looked at more sustained. I had her go up for a longer period of time on a higher books. She said it felt a lot less tension than it used to when she went into sustained extension. So we kind of stuck with our program since she had seen such a big jump. Extension and standing, sustained a little bit. She can get some mobilizations if she wants. But continuing with this kind of policy or this program of increasing lumbar extension in terms of movements and exercises throughout the day regularly, every couple hours, and also reducing the amount of lumbar flexion and sitting by using the roll and the car seat wedge. So visit 4 was about 2 weeks later. She had a trip, but she was still able to get some sustained extension about 3 times a day and some extension in standing over the kitchen counter. We'd always used a fulcrum like a kitchen counter. She felt like the right thigh the groin was better. The left hip was still getting better in terms of improvements in pain, improvements in that feeling of strength and stability when she went upstairs. She reported she could carry 4 bags of groceries upstairs now, and she was fine. She changed to a smaller night roll that seemed to make more sense for her. She bought a new chair for work. The only time she was getting that left or below the knee symptoms were the left calf would cramp at night and no other leg symptoms. So we did talk about, I just wanted to, understand, like, do we think this is related? It's not an electrolyte deficiency or something else. She's like, no, this is definitely related to this problem, or it came on at the same time. So we still contributed that to the lumbar spine and as a symptom that we still needed to get rid of. So left below the knee symptoms still apparent at night. The left side glide was moving a little bit better in the physical exam. The chair step up was still there, but better, meaning still slightly painful on the left with some weakness, and the right hip felt a little bit tight and a little bit weak. Other mechanical findings were not significant. They're about the same as prior. So I decided to go out of extension because that left side glide had not really resolved. It hadn't resolved. It was not equal to the right side glide. There was still an asymmetry of movement in the frontal plane. We looked at left side glide on the wall. We did 2 sets of 10. It would produce low back pain but not remain worse afterwards. I decided, because she seemed like she responded well to sustained postures of the lumbar spine and extension, to look at sustained side gliding. So I had her hold it for about a minute. It didn't hurt. Afterwards, she felt an immediate improvement in terms of her flexion and extension, side gliding, and the step up. So I decided it was time to move out of extension and explore hitting the lumbar spine from the left, no longer hitting it from 6 o'clock, but hitting it from 9 o'clock. This is a joint mobilization, but it's just a joint mobilization the patient does independently, using the side glide against the wall with a pillow for support if needed. So that was her home program. I said, let's do some side glides on the wall every couple hours, knock out a set of 10, hold the last one for her up to a minute if you can. And I even said, with a person who gets it, I could say to her, look, if this side glide has no effect in 3 days, let's go back to what was working, right? Let's not deviate from the path. If there's a change, it should happen within a couple of days. It should not take very long, because there is less involvement in terms of a side glide versus extension. With extension, there's a lot of things that we could possibly be changing slowly, but side glide, it's really, let's just see what happens when we hit only that left side of the lumbar spine. So we talked more about posture, reclining in bed at night, things that maybe we hadn't quite picked up on initially. And I told her that we were really trying to see if this left side glide could eliminate that left calf pain that was still lingering below the knee, because we don't want symptoms below the knee. That really speaks to, a little bit more involvement of the nerves in the lumbar spine. So visit 5 was about a week later. She reports about 85% better overall, and that the side glides on the wall were fruitful. She had no pain going upstairs. The calf raises felt better. Car transferring was good. She had a day where she couldn't do many side glides and had to do a lot of moving and lifting, and she did notice that she felt a little bit worse on that day. So she noticed that one-to-one relationship. She did not have time to test a jog that we had possibly discussed. She noticed that the calf cramping at night was better and had no calf cramps in her leg that week. So cramp, spasm, pain, we can possibly use those interchangeably. What I care about is that there's no left calf symptoms below the knee that week, which we think was due to doing the left side glides of the lumbar spine. So mechanically in the physical exam, the chair step up on the left now produced left low back pain, but the hip felt better. Straight leg raise test looked about the same, limited but not painful. Flexion in lumbar spine still limited but a little bit better. Extension still limited, and the side glide was approximating the right side glide, but it still wasn't free. It still wasn't moving as well as the right, but neither the left side glide nor the right side glide had been painful to begin with. So I was just curious if maybe we needed to split the difference and look at, extension in the left side glide. So extension with hips off center, hips to the right. We looked at that. I had her lying prone in extension with the hips to the right. It produced some left low back pain and right groin pain. I did some gentle mobs in that position just to gauge the effect. And then she did some extension lying with hips off center with the hips sag at the end. It seemed to improve some of the side glide even more and decrease that pain in the left low back with the step up onto the chair. So I said, I wasn't quite convinced that we had to be kind of this particular about the movement, but some people really do need, instead of 6 o'clock or 9 o'clock, they need 7:30. So I said, again, you're 85% better. I don't want to mess up a good thing, but let's just see if maybe getting it slightly differently, hitting the angle slightly different of the lumbar spine would help us get all the way there. So I had her doing hips off center extension, which is challenging when someone's really stiff, to be sure, but she understood it. She repositioned if she got back to center, getting up all the way with the hands, sagging at the top. Visit 6 was about almost 3 weeks later, and she said she'd had no pain for the last 2 weeks at all. She decided to stick with some side glides on the wall, so she was doing some side glides on the wall 3 times a day because they were really easy to do, and she did the extension with hips off center about 3 times a day. Her posture was better. Each time she came in here, we kind of had this, small, lighthearted conversation about the way she was sitting in the chair when we were speaking, and I could notice over the course of 6 visits that she did tend to get better. So the awareness takes time, the habits take time to form. So she was doing better with that, and I do believe for many patients, not all, the continued or the sustained position of how you sit has a big impact on the lumbar spine. So that's why it was important for us to kind of keep talking about that throughout the course of care. So stepping up was better. She hadn't tested any jogging. Sometimes when she has to sit at work, she'll use something under her hips to help her achieve a little bit more lumbar spine extension. Movement exam, about the same. And the chair step up was normal though. That was great. So no pain in the hip or the low back, no weakness reported. But mechanically, moving the lumbar spine, moving the hips still seems stiff, but better than initially. So we decided to see if, I didn't see her again, but we decided we're ready for discharge. And I think our maintenance program, since she's been pain-free for 2 weeks, was to just try to get some extension in her lumbar spine on a maintenance basis, and to try it, 3 times a day, and then possibly reduce as she sees fit, maybe once a day, maybe twice a day, whatever she sees works best for her as a person to maintain all these improvements that she made. I thought that extension would be enough. We didn't need to stick with any side glide or extension with hips to the side. And she knows she could call me or come back in if that doesn't work, but it seemed that we had proof that just maintaining that extension now that we'd achieved and not going laterally would be the best thing for her, especially in conjunction with all those postural changes. And that's another kind of key point I think that this case brings up. One, the cost and the value of care, which I mentioned at the outset. 2, also the fact that her other physician thought this was a hip problem. And I think one of her consults with a physician had also said we could go in and do some surgery. They found some labral stuff. They found some degenerative changes in the hip. They found degenerative changes in the lumbar spine. I just thank goodness that we had this opportunity to at least delay it. I mean, on our last visit, we talked more about arthritis, and I said that I agree with the findings on the x-rays and MRI, that there's probably there are arthritic processes going on in these joints. I gave her some information about arthritis, possible triggers, dietary changes, possible insulin resistance, other things, and said, let me know if you'd like me to help you navigate this more. But I think there are some strategies you could take if you want to try to at least prevent the arthritis from, deteriorating even more. But, if someone had offered labral surgery and you're in a lot of pain, a lot of people take that option. Again, an MRI is just going to show a finding. It's not going to show you if it's related to your symptoms. So even if she does have labral tears in one or both hips, we were able to successfully eliminate those symptoms with simple movements. I think the movements of her lumbar spine were what fixed this entire clinical picture, but one could make an argument that I don't know, because when we moved her spine, most of the time we were also moving the hip. But so the cost, the value of care, the physician saying this is hip dominant, the physician saying we could do surgery. Another point of this case is that we didn't see a lot of mobility changes. She remained quite stiff, but we got enough that symptoms were abolished and that she was back to pain-free after 7 months of pain, able to resume jogging, I think, because she had tried it, but she had been busy, but definitely able to do more activity in terms of going up and down stairs, carrying things, getting in and out of the car, staying in the car without pain, carrying groceries up and down steps, things like that, or sleeping without leg pain. So mobility, not major changes. So we have to go by other things as well. I definitely no worsening of lumbar or hip movements. Straight leg raise testing obviously became pain-free, but still very limited. And hip range of motion a little bit less painful, but still quite limited. The mechanical findings that I use to usually drive decision making, because we didn't have strength changes that we're really paying attention to, they were informing what I did, right? Especially that loss of left side glided lumbar spine. They were informing where we went, but I had to listen to symptoms more than see observable changes in motion, because they were not really readily apparent. And I even showed her on the last day, or the second to last visit, this is what your extension looks like in lying. I just want you to know that I would love it to be a little bit more fluid and for that lordosis to appear when you go into a press up on your stomach, but it's just not there. It's kind of like a board. And she agreed. She could feel it. She could see it. So that was part of our conversation about arthritis and what she could possibly do, with my guidance or working with a professional who's more versed in kind of arthritic treatments. Although I don't think there are a lot of good healthcare clinicians out there who are really trying to get to the root cause of a patient's arthritis. I believe there are root causes of arthritis, whether or not it's metabolic or food triggers, or some doctors even talk about bacterial infections that can contribute to multi-joint arthritis. But I think that that's part of her presentation and why she's so stiff. So this was an interesting case, to say the least. She was, a patient who was extremely easy to work with, someone who actually did the program every few hours, which is challenging, but worth it when it shows results. But basically we're trying to get data. What happens when you extend your spine 6 times a day? What happens when you side glide? And if it's improvement, then obviously we can call it the treatment. But at its core, it's really assessing the effect, because if I move her spine in lots of different directions and nothing changes in her hip, well, then we can say we've ruled out the spine. The testing was effective at ruling something out. But like I said, at the end of the day, a really good case that kind of highlights a few different parts of American healthcare, American medicine, and proves to us that we can't go necessarily by an MRI. We can also say to ourselves that we understand that different types of physical therapy are different. Physical therapy is not a homogeneous type of treatment. Physical therapists are like any clinicians. We do things, well, not any clinician, but we work differently. We do different things. I use my hands on her low back to assess what happens when I mobilize her into lumbar extension, but it's hard for me to call that a treatment necessarily, because I was really trying to mobilize, assess the effect, mobilize, assess the effect. I did have her husband do some mobilizations, that's a treatment, but it was very movement based. My treatment for her was not about soft tissue, was not about strength, it was about how can we get you mechanically moving better to eliminate those symptoms. So different types of physical therapy are out there. We all do things a little bit differently, and I think at the crux of the matter is that we do things differently because we understand things differently. I did not understand that her labral tear on her MRI was causing all her hip complaints, or I did not believe that the MRI and the x-ray of her lumbar spine, which showed degenerative changes, was the main thrust of why she had symptoms. I think they're there, and I think they're contributing to stiffness, but it seems from repeated movement testing over the course of our care, which is about 7 weeks, that we can get that lumbar spine moving better and get her feeling better. So a lot of different ideas are encapsulated in this episode of care. Please let me know if you have any questions.